Good evening. Welcome, everyone. Thank you for joining us tonight. I'm David Dodick. I chair the American Brain Foundation's board. And tonight we have an exciting program with a special guest who's going to talk to us about concussion and the treatment and management of concussion and preventing persistent symptoms from concussion. So a really important topic. Our foundation, as you know, is committed to sharing valuable resources and increasing public awareness of brain diseases, and our webinar events like tonight are opportunities to connect you all with experts in various topics of interest around brain disease. And the American Brain Foundation funds, as you know, research across the entire spectrum of brain diseases, because we know that many of them are interconnected, and curing one, we believe, will lead to a cure for many. And concussion, our topic tonight, we're just launching a big neuroinflammation initiative, because inflammation, for example, is, we believe, a thread that links many diseases, including concussion, but also things from multiple sclerosis to Alzheimer's disease. So let's move on to our topic of conversation for tonight. Receiving a prompt diagnosis and having appropriate care for concussion, otherwise known as mild traumatic brain injury, which in itself is a topic of conversation, managing that appropriately will decrease the severity of symptoms that athletes and other people have when they experience a concussion, but also there are techniques to facilitate recovery and reduce the risk of symptoms persisting, which can happen in about 1 in every 5 people who actually experience a concussion. So it's not, unfortunately, not rare that this happens. So tonight we'll discuss what can be done after the injury to speed recovery and reduce the risk of symptoms persisting, as well as reduce the risk of some of the other serious long-term effects of concussion. This is a subject that's very important to me. I myself was a competitive athlete playing a contact sport, ice hockey, growing up in Canada, and I sustained a fair share of my own concussions. And I've been evaluating athletes and military operators since 1996 with concussion. And I started the concussion program at the Mayo Clinic in Arizona back in 2010. And I continue to be involved in research and education around concussion. And indeed, I've collaborated on a number of projects and continue to do so with our guest speaker tonight, Dr. John Leddy, who I'm really pleased to introduce. Dr. Leddy is a professor of clinical orthopedics, internal medicine, and rehabilitation sciences at the University of Buffalo School of Medicine. And he's currently the medical director of the University of Buffalo Concussion Management Clinic. His research interests focus on investigating the basic mechanisms of what gets disturbed and disrupted physiologically after a concussion, and how to restore that physiology back to normal to help speed recovery and provide safe return to activity and sport for people who have been concussed. His research actually has led to some seminal findings and really landmark publications in the field that has changed the face, not hyperbole, of the way concussion is actually managed around the world. Until Dr. Leddy's research, individuals with concussion were essentially cocooned in quiet, dark rooms and basically put to rest. And today, as I think you'll hear, Dr. Leddy created the Buffalo Treadmill Protocol, which allows for a diagnosis, prognosis, and the treatment actually of concussion. It's become the standard of care for the treatment of concussion among experts in the field, and is increasingly recognized, I think, by primary care physicians and everyone involved in evaluating athletes as essential in the management of the concussed athletes. So we're really privileged to have Dr. Leddy here to speak with us tonight, and the floor is yours, Dr. Leddy. Thank you for joining us.
Well, thanks for that very nice and somewhat exaggerated introduction, David. I'll have you introduce me at all my talks from now on, if you don't mind. But thank you very much. It's a pleasure to be here speaking to the American Brain Foundation. I am not a neurologist, so full disclosure. I hope to be one someday like David. But I got into concussions sort of through the sports medicine aspect of things. Back in the 90s, I did a sports medicine fellowship training, and I was a team doctor and still am for many years. And I was seeing lots of athletes on the sideline, in the training room, and in my clinic who had concussion. And I'll just go back to that time because David alluded to it. when I first started doing this, really the only thing we told concussed patients to do was rest until all of your symptoms go away. It was sort of considered verboten to have somebody do too much mental or physical activity soon after concussion because it typically reliably increases someone's symptoms. And it was thought that based on sort of some early animal research and expert opinion at that time, that if you increase the symptoms even a little bit, you were harming the brain and delaying recovery. Surprisingly, there wasn't very much research to actually support that approach back then. And so I was lucky enough in my institution to have a collaboration with my dear friend and colleague, Barry Willer, who some of you in the brain injury business may know. He is a professor of psychiatry at the University of Buffalo, and he had an interest in more severe brain injury, in which he's an expert. But like David, he's also Canadian. And in the late 90s, the Canadian Hockey Association charged him with coming up with some return to play guidelines for hockey players, not only in Canada, but all over the world. And so he came down to my end of the building and we struck up a collaboration. I should say that back then, after we talked for a while, his recommendation to Hockey Canada was the athlete should not go back to play until he or she has been seen by a doctor. That was his recommendation back then. And that largely holds true today, I think. But the other thing that we started talking about was, could we treat athletes a little more actively rather than telling them not to do anything and hoping their symptoms went away? It was my observation that worked in about 7 out of the 10 athletes that I was taking care of. But what about the 3 of the 10 or the 30% or so who that wasn't working for? And in fact, they were getting worse with time and not better. And, you know, I don't think it's too hard to imagine that if you take a young person who has a head injury and take him or her out of their sport, away from their friends, out of school, and sort of isolate them, that some of them are going to actually get worse, especially in terms of psychological symptoms, anxiety, feeling depressed, emotional. And that gets worse as time goes on and your symptoms aren't going away. So this is, again, I'm not going to be too historical here, but if you take the principles of somebody who has heart disease, for example, and you want to rehabilitate that person from having a heart disease or a heart attack, what do you do now these days? Well, you have a cardiac treadmill test, you have a stress test. And what's the purpose of that? The purpose is to actually produce the symptoms in that person at a certain level of exercise, and then use a sub-threshold or a lower level of exercise to rehabilitate them. That is now the standard of care for cardiac patients throughout the world, as has been for decades now. Interestingly, that was largely developed by clinicians and researchers at my institution at the University of Buffalo in the 1960s. So I thought, why not apply that, but to the brain? And so David alluded to the Buffalo Concussion Treadmill Test. So we decided to try to help athletes exercise, but at a level that didn't significantly increase their symptoms, so we could just get them moving again and hopefully reduce some of their symptoms, maybe make them feel better faster. We didn't know how it would work in the beginning, but we sort of borrowed a treadmill test protocol from the cardiac rehabilitation literature because it was very safe. You could do it after someone had a heart attack. And we started measuring their blood pressure and pulse on the treadmill, and we came up with a way to assess how much their symptoms went up during exercise. And predictably, they did. So we took a heart rate at that point, we called that the threshold, and then we gave them 80% of that heart rate to go back to their gym or the training room and try to do some exercise just for 15 or 20 minutes per day. And we told them to stop if their symptoms went up more than mildly, and we defined that for them. Anyway, in the beginning, we only did it in the patients who had prolonged symptoms, and that's defined as symptoms more than a month. In fact, back then we were doing it in patients who had symptoms for 2, 3, 4 months and more. Again, the reason was we wanted to be very safe. Back in the 90s and 2000s, it was thought that if you were provoking symptoms in someone with the concussion, you were harming their recovery, you were delaying it. And so we did a small study initially in some of these patients with prolonged symptoms. Dr. Dodick said, that's about 20%. And that's about right. In adolescents, it's more like 30% if you don't do anything. They'll have symptoms more than a month. And in those patients who we did this in, we did it half in athletes of college age and half in some older adults who were hurt at work. It seemed to work. It seemed to help them recover faster and get back to either sport or work. What was interesting was that the athletes recovered in about a third of the time when compared with the adults. And there are probably several reasons for that. So the other thing we sort of got interested in is why do people have symptoms that increase with physical activity? And why might exercise actually help them? And one thing that sort of ties that together, and Dr. Dodick alluded to this in terms of my interest in sort of physiological mechanisms, is the part of your brain called the autonomic nervous system, which essentially controls your ability to breathe and pump the blood throughout your body and to your brain. So it's the deepest, most primitive part of the nervous system. It's responsible for breathing, heartbeat, blood pressure, blood flow to the brain and the body during exercise. So we were one of the first to think about that, and we did some experiments to try to show that, in fact, the autonomic nervous system is disturbed after someone gets a mild traumatic brain injury or concussion. And we don't know a whole lot about it because it's challenging to study, but we do know that people who have concussion sort of have an engagement problem with the autonomic nervous system. That is, the autonomic nervous system changes your physiology in response to the environmental demands on you. So, for example, if you're going to get up and exercise, you have to increase your heart rate, your cardiac contractility to pump blood to your brain and your muscles. That's all under the purview of this autonomic nervous system. And so we and some others have shown that that's actually impaired after concussion. The other thing that relates to is the control of blood flow to your brain. So when you're at rest, like you are right now, I hope, and you have blood going to your brain, that's sort of, a steady state. But if you had to get up and run out because your house was on fire, you'd have to increase your cardiac output by 5 or 6 fold, even 10-fold in some people. And you'd have to get your muscles going, and you'd have to run out. Well, what happens to your brain blood flow? Well, it certainly goes up, but by only a fraction of what is pumped to the rest of your body. That's because your brain regulates the blood flow to itself very carefully. And we've shown, too, that aspect of concussion is also a problem for not only athletes, but everybody. So that control of cerebral blood flow after a concussion, especially during exercise, is poorly regulated, let's say. And we think that's one of the reasons people get symptoms when they're exercising in the early days and weeks after a mild traumatic brain injury. Okay, so that's sort of a roundabout way of saying that one reason we thought that exercise might help patients with concussion, if we did it the right way, is that exercise is sort of the best medicine for an autonomic nervous system that's been thrown off of kilter. There are drugs that can affect autonomic function, as any neurologist on the panel knows, but they tend to affect different parts of the autonomic nervous system. There's the sympathetic part, or the flight and fight branch of your autonomic nervous system, and then there's the parasympathetic, or rest and digest branch of it. And we have different medications that affect different aspects of that. But exercise, actually, aerobic exercise specifically, actually treats the whole autonomic nervous system. It's sort of the best medicine you could have if you were going to put it into a pill and give it to somebody who had autonomic dysfunction from any cause, really, even from concussion. So fast forward, we started to become interested in doing this in athletes who had concussion acutely on in the acute phase, that is in the days and early weeks after the injury, before they had this delayed recovery, this prolonged post-concussive symptom syndrome. Okay, and using the principles of the treadmill test, we did a couple of studies in adolescent athletes where we saw them within 5 or 6 days of the injury, certainly within about a week. And they were all symptomatic. You know, people who have had concussion, if you've ever had one yourself or you know somebody who's had it, usually they're still pretty, impaired within the 2, 3, 4 to 7 days afterward. But we had shown in a prior study that doing the treadmill test in that time frame early on in adolescence was actually safe. If you did it the right way, you didn't give them more symptoms the next day or delay the recovery. So we decided to use it early on, give them this exercise prescription based on the results, and we call it exercise as medicine for concussion. And we did what's called a randomized controlled trial, where we gave half of the people were assigned to the exercise program randomly, and the other half, they did a placebo-like stretching program. So they were stretching, but not increasing their heart rate as they were doing with the aerobic exercise. And in the first study, we showed that actually worked, that giving the exercise early on sped recovery by about 4 or 5 days versus the kids that got assigned to the stretching program. Now, unfortunately, in that study, I was very interested in whether doing that would prevent a significant portion of these patients from going on to this delayed recovery that Dr. Dodick talked about. And let me just say for a moment that's really the part of, at least in adolescents, but also for everybody. If you have symptoms for more than a month or 2 months, that really interferes with your quality of life, with school performance. They're missing entire seasons of sport. They're losing out on social interactions in school. It's a big deal at that age, as you can imagine. And so it's really that group that we were hoping to impact as much as anything. But in that study, we did not have a statistically significant impact on those who went on to a delayed recovery. It was only about 15% of them, or 10 to 15% that went on to that delayed recovery. So we didn't have enough subjects to show that. So we repeated the study with more centers across the U.S., well, in the Northeast, I should say, and some more impaired subjects. And in this study, the second study, we found that when we looked at the data, those that got the exercise early on, a mean of, I think, 4 days from their injury, not only recovered faster than the guys that got stretching and the gals, but they had a 50% reduction in the rate of this delayed, prolonged recovery that we define now as symptoms persisting more than a month. So what can you do to help somebody recover from a concussion in 2023? Well, the first thing I think is to get them seen as early as possible. There's some good data now in the literature that the faster somebody gets in with a physician or provider who knows what he or she is doing with concussion, the faster they recover. And it's a fairly significant effect. That is, the biggest predictor, or one of the biggest predictors of delayed recovery, is how soon you get seen by a physician after your injury. So number one for the folks in the audience is that if you have a concussion or a loved one has a concussion, try to get them in with somebody as soon as possible. That makes a difference. Because if that provider is up on the latest sort of advice and research, they will avoid the mistakes that were made by us doctors for decades almost, in that they'll avoid having them rest in a dark room, with no contact with their friends and no exposure to light, things like that, hoping that rest will just take their symptoms away. We know now that is actually detrimental to recovery. It doesn't promote it. It's actually harmful in terms of recovery. It is helpful if the provider knows something about concussion, but the most important thing, I think, is getting someone in to seeing someone, even if they're not comfortable, then they can refer on, hopefully, in your area. So that's one of the most important things, is sort of rapid evaluation. And then, not everybody can have a Buffalo concussion treadmill test. Not everyone has access to it. But after the first 48 hours, where we tell people now not to strictly rest in a dark room, we tell them to relatively rest. What does that mean? Well, that means, stop playing your sport, don't do any intense exercise, but also get out into your environment a little bit, walk around, do some chores. You can watch TV, you can text your friends. We also, however, tell them in the first 48 hours to minimize screen use as much as possible. So we don't want them on their phones all the time or on their computer, because that has been shown actually to help speed recovery in the first 48 hours after injury. If you minimize screen time, you actually help them recover. Now, beyond that, it does not appear to be effective beyond the first 48, but certainly in that early phase, minimizing screen time appears to be one thing that's fairly simple to do, and that's got an evidence base around it for efficacy. And then we just want them beyond that first 48 hours. Hopefully their symptoms are stabilizing a bit. They're not doing too much, but they're not doing nothing either. And then they can start becoming more active. And we use the more than mild symptom exacerbation rule. So I tell patients, look, if you don't have access to a formal treadmill test, what you can do is start walking, or maybe a stationary bike, or walking on a treadmill, and do it until your symptoms go up more than mildly. And how do we define that? We define it as an increase on a 0 to 10 scale of 2 or more than 2 points during the activity when compared to your pre-activity value. So I know that sounds maybe a little complex, but as an example, if someone felt that they had a 3 out of a 10 headache when they started, and they started walking, or maybe riding a stationary bike, and in 15 minutes it went from a 3 to a 6 out of 10, then they should stop. But if it doesn't, if it only goes up by a point or two, we know it's safe to continue to do that for a little bit longer if you'd like. And another thing our data recently have shown is that what people do in that first week is important. That is, the more that an adolescent can exercise at that subthreshold level, the more volume they get in, they tend to recover faster. So it's really about identifying this sweet spot of activity, whether it's thinking or physical activity. That is, you don't want to do too little or nothing, and you don't want to do too much. And so we talked a lot about identifying cognitive and physical thresholds, and then trying to stay just below them, but getting things done. And how do you do that cognitively with schoolwork? Well, you tell them to take scheduled breaks, for example. That's another thing that can help early on, is they can do cognitive activity, but should stop if the symptoms go up by more than 2 points. You can do it the same for your brain. Or we tell them to take a scheduled break every 15 to 20 minutes, let's say, or when the symptoms go up when they need to. So in that way, again, you can sort of gradually get your brain adapted to cognitive function, as well as your body to physical function. So a concussion is a brain injury, but it has widespread physiological effects throughout the body. And while, I don't want to paint an oversimplified picture of it, but one of those aspects is the control of your blood pressure, your brain blood flow, and your ability to exercise, et cetera. The other thing that is very common with prolonged symptoms, we've learned now is that you may have heard the term in the past, post-concussion syndrome. Now, post-concussion syndrome simply meant that someone had a head injury, but they hadn't recovered from it for usually some months. Dr. Dodick will know that it used to be defined as 3 months or more of symptoms, typically in someone who had an injury at work, let's say, or a car accident, or maybe a more severe brain insult. That was sort of in the non-sport literature. In the sport concussion world, it's considered more than a month. And what we've learned that, and there's Dr. Nathan Zasler, who probably everybody knows on this call, who's involved in neurology and concussion, who says, it was never a syndrome to begin with. A syndrome is a defined set of signs and symptoms that defines a single entity in terms of a disease process, and persistent symptoms after concussion is really anything but that. And what we learned over the past, 5-10 years is that in someone who has these persistent symptoms, it's up to the doctor to figure out why. And to do that, you have to do things like a basic physical examination. Sometimes you have to do additional testing. You might have to do a cognitive test. You might have to do an eye movement test. We've learned that many concussions are accompanied by neck injuries, which shouldn't be surprising, but wasn't realized until maybe a decade ago. And I used to get patients referred to me who had ongoing symptoms for months and sometimes longer after a concussion, quote unquote. And after we evaluated them, we said, well, I think your concussion's over, but your neck is messed up and no one's ever pushed on it and no one's ever treated it. And lo and behold, you treat the neck and their post-concussion syndrome goes away. So I think one thing that is becoming very clear in the field is that if doctors can see the patient on a weekly basis, typically, and that's how I see my sport concussion patients, you can identify these problems that are persisting and are going to lead to delayed recovery. And what you can do at that point is intervene. And by intervention, I mean things like physical therapy for your neck, vestibular therapy for the balance problems, very common after concussion. If anyone saw the Miami quarterback in the Buffalo Bills game, when he got up, he stumbled, his vestibular system was off. So that's really common. That can be treated. And we know now from recent data that can be treated even earlier than we thought before, and successfully. So my practice is changing a little bit in that I'm starting to employ these other therapies a little bit earlier than I used to. I give people about 2 weeks to declare themselves, but if they're not getting better in terms of vestibular function or oculomotor, which means eye motion function, we're thinking about instituting therapy at that point, because we don't want people to go on to this delayed recovery, because it really affects everybody, but especially kids in school, very profoundly. So I might just stop there. I think I've droned on and on, David, and see if you want to ask a question or anyone else does.
Sorry, I couldn't unmute myself there. No, that's perfect, John. Thank you. 30 minutes on the nose. So I want to leave time for people to ask questions. Very practical advice from Dr. Leddy here. And maybe we'll start with, we'll open the floor. There's a number of questions here already in the chat, but Jim Hearn, you have your name up. Would you like to ask a question?
Yes, thank you very much. My question is, how long does it take to develop CTE? My brother-in-law played college football and played pro football briefly, and it seems he's developed short-term memory problems. But I don't think he's been evaluated to determine if he has CTE, because I understand the only way you can do that is through an autopsy. but I just was curious if there was any research about that.
Well, I wish I had a good answer for you, Jim. I don't. I don't think anybody knows definitively how long it takes to develop CTE. It appears that in those who are probably at some sort of genetic risk, if they are put in the environment of repetitive head impacts, and by repetitive, I mean years and thousands of them, especially retired professional athletes who played American football or soccer, for example, they can develop a neurodegenerative disease, and some of that may be CTE. And you're right, it can only be diagnosed right now post-mortem on examination. If your brother is having memory problems, though, he should see a memory neurologist specialist or somebody who's versed in assessing for, again, memory problems, because there's lots of different reasons people have memory problems. And Dr. Dodick is far more capable of talking about this than I am. But I have patients like your brother, and that's what I do. We have a memory clinic up here with a very well-known, again, neurologist, Dr. Seghetti, who's got NIH grants and things like that. So I have somebody like your brother evaluated for what may be treatable or reversible causes of memory problems, okay? Remember, CTE is a diagnosis completely of exclusion at this point. We just don't have the data to tell us who is going to get it, how bad it is it progressive, et cetera. Now, maybe in 10 years we'll have that because a lot of research is going on right now. But I think that's the best way I can answer you, is that I don't know how long it really takes, but I would have someone like Dr. Dodick or another competent memory neurologist evaluate your brother just for a thorough evaluation, because there are many different reasons why people start to have memory problems.
Yeah, I I don't really have much to add. I agree with everything Dr. Leddy said. And from a research standpoint, you asked the question, is there research going on? And there's a lot of research going on in this area. And I'm part of an NIH study that involves the Mayo Clinic, Cleveland Clinic, Boston University, New York University, and other institutions. It's an NIH study known as Diagnose CTE. And we have 180 former collegiate, and former professional NFL players, athletes. And we also have control population, people who never played a contact sport, were never served in the military, and have no history of concussion. And we're following them, we're evaluating them in a very detailed way, both clinically, and we take spinal fluid and we take blood, and they all get imaging of the brain, very sophisticated imaging for amyloid and tau. And so we do PET scans, and we're following these people over time. And the reason it's called Diagnose CTE is the whole purpose of the study is to develop a biomarker, a test that we can administer before people die. Because right now, as you've said, it's only something that can be diagnosed at autopsy. So the whole purpose of this trial is to develop basically a test, a diagnostic test that we could implement in practice for people like your brother, or anyone who played a competitive sport or had a history of repetitive head injuries, where we could potentially make that diagnosis. Because it's only then, when we have that biomarker, that we'll understand certain targets that we should be looking at for future therapies. So a lot of research going on in this area, but I agree with everything Dr. Leddy said. He really needs to be evaluated by usually a multidisciplinary behavioral neurology team who are expert in cognitive decline, dementia, and that usually means neuropsychologists, neurologists, a very multidisciplinary team. So that's what he needs. Let's see. Marianne, you have your name up. Your hand up, sorry.
Hi. Can you hear me?
Barely.
Okay, is that better?
Much better.
Okay, thank you. I'm going to put my camera on also. Okay, there we go. So I did put some questions in the chat. first want to say thank you for doing this today. I had a TBI. It'll be a year on the 22nd of February. And I really don't want to discuss maybe all of the past situations, although it portends to what's going on now and the fact that I am still adversely being affected. And I didn't have the proper treatment. So I'm a healthcare provider of 40 years. And I, for instance, took my mom to Johns Hopkins for over 10 years to get her what she needed. And here I am. I know that I fell through the cracks with everything. And I'm wondering going forward, I mean, how many practitioners know about you, Dr. Leddy, and how many practitioners in this field are willing to implement what you have, not only for myself, but I've talked to parents, children, who've had TBIs with sports related injuries. And I'm just concerned, I've had seizures since I was 16. And unfortunately, this is my second head injury. And I'm very concerned about the care of the brain and its impact and what happens as you go forward. A lot of things were not offered to me. And I'm saddened to hear that. I'm wondering if there's standards in place, if there's any impetus to have standards in place. And you mentioned something which I found very interesting, because this is a mantra that has been repeating itself. Physicians not knowing or being able to provide proper care for someone who's had a TBI. That's me and a lot of the people that I've talked to. Unfortunately, it's happened. What can we do? You know what I mean? I know I have specific needs. I don't need to discuss it here. You know what I mean? I could probably just call the office and ask some questions. But honestly, I think nationally, we need some momentum here. And I'm concerned. I'm very concerned.
Well, yeah, I think that's a legitimate concern. I think I read something, and David might correct me, but it takes about 10 years for something new in medicine that's discovered to make it through to routine clinical practice in some instances. It may not be everything, but that's not unheard of. So how many people know about this? I don't know, Marianne. I can't tell you that. I think in the sport world, a lot of people know about it because trainers and therapists and sport doctors, have come to realize it works. But permeating that, through to primary care doctors and other healthcare providers, who take care of brain injured patients, is probably, or I'm sure, is more challenging. And as far as national standards, that's the goal of everybody, I know, but achieving that is another thing. Societies like the American Academy of Neurology will have position papers, and so will other societies. There are position papers from the American Medical Society of Sports Medicine, et cetera. So there are guidelines out there for people who want to learn more about this and how to take care of patients. There are no official sets of clinical rules or anything that people adhere to, I don't think. Recently, we had a meeting in Amsterdam for the International Concussion and Sport Group, and that will be a widely circulated document that I hope lots of providers will read, at least the main statement. So that will help too. That updates the information every 4 to 6 years on sort of the best way to treat sport concussion, but it applies to lots of non-sport concussions as well. So it's a challenging area. I don't have a very good answer for you. Other than that, maybe in your area, you could try to find a university-affiliated clinic or neurology practice that has some experience with TBI, and ask them if they're up to date on the latest treatments. I don't know if David has anything to add to that.
Yeah, Marianne, I'm sorry for what you continue to go through. In my practice, this is almost all that I see is people with persistent, prolonged post-concussive symptoms. And I can tell you, I don't know how many people know about Dr. Leddy's protocol. Mm-hmm. I think he's right. Everybody in the sport world knows about it, and certainly experts in the field know about it. But if I could just think in my mind of the last 100 patients I've seen who were referred to me, how many actually went through that protocol? It can't be more than 1 or 2.
Right.
if it's that. And so the answer to your question is, I think, very few. And the reason, as Dr. Leddy said, it takes about 15 to 17 years for something to be integrated from the time it's discovered into clinical practice.
Mm-hmm.
And the only solution for this, I think, I went through my neurology training without a stitch of education or training in the diagnosis or management of concussion. And so not only did I go through medical school like that, but I went through internship and residency like that. And by the way, neurology was very late to this field, as Dr. Leddy will tell you. And it's only been over the past decade or so, in 15 years, that neurology has really taken an interest and a focused in this area. So the problem is that you need to get to people in their training, in the undergraduate or postgraduate training. So, at my institution, every trainee goes through or does a rotation in the concussion program. So they get trained on how to recognize and how to manage concussions. So when they go out into practice, it's just part of their standard operating procedure. They know how to manage this problem. As opposed to those who get out, they're in practice for 5 or 10 years, and they're dealing with everything that's coming at them. Alzheimer's disease, Parkinson's disease, multiple sclerosis, epilepsy. It's very difficult to keep up with all of these fields. And so unless you've taken a specific interest in an area like this and you haven't been trained in it, it's very difficult to implement all of the new findings. So I think the only way to get at this is to get into undergraduate and postgraduate medical education and training so that future generations of physicians are able to take this forward.
Okay. I understand, I truly understand what you're saying. Thank you very much.
You're welcome, Miriam. Hope you feel better.
Okay. Thank you.
Good luck.
Thank you.
Jennifer.
Hi. I have a question. So I'm a neuropsychologist, so I know a little bit about this field, but I have a grandson who lives in Steamboat Springs, Colorado, a huge place for recreational and athletic skiers. That's where we do a lot of our training. And my 10-year-old grandson, for 2 years in a row, has had TBIs as a result of ski jumping. And his parents and I am concerned about allowing him to continue. Now, one of the things that I really did appreciate was that his mom, our daughter, took him right to the pediatrician. They did, testing of his ocular capacities and things like that, but I didn't hear anything, and I'm sure I would have because I asked a lot of questions about Dr. Leddy's protocol. And the next time I go to Steamboat, I definitely am going to go talk to those pediatricians. They did tell Ryland he couldn't do screen time for a while, but they didn't challenge him in having him exercise. They didn't do any of those things. They told him to be still for a month and to not do screen time and the dark room and all the other things that you described. And I can completely neurobiologically relate to what you're saying, Dr. Leddy, about the protocol. And so I'm wondering, because now his parents are concerned about allowing him, it is ski season, to participate in all his sports. He's very athletic and very good at it. And whether, because they're worried he'll have another concussion. He's had 3 concussions so far as a result of his sports.
And he's 10 years old?
Yes, he's about to turn 11 in May.
Okay.
And I'm worried, yes, he's developed anger management challenges. And I, as a psychologist, I can't help but think that and because I've taken quite a few classes in neurobiology at Stanford and UC Berkeley. I'm in California. So, I'm concerned about that.
Well, I think a 10-year-old who's had 3 concussions already probably warrants some concern. I don't know how close they were, how severe the head injuries, all that information makes a difference when evaluating somebody who's had repetitive concussions. If they were telling him to be quiet for a month and not do anything, I think they are not aware of the latest evidence-based research. So that is an issue. And one of the, and if he had a delayed recovery, either with this one or the other ones, it may be as much the advice he's getting for how to manage it as anything else, right? If he's not being allowed to do much, we know now that that's not very good. We can't go into this in too much detail, but anyone who's 10 years old and has had its third concussion already, in my practice, I would be having a discussion with him and his parents about whether this sport is worth it for him. Now, again, I'm not going to make any generalizations because I haven't seen him and I haven't talked to him or anything, but somebody who's had 3 concussions by the age of 10, we know for sure is at a higher risk of having more of them. And if he's ski jumping, that's not like, a running track. That's a high risk sport. And, he'll probably have more of them if he continues in this sport, to be quite honest. And, we don't know how many is too many, and there are individual factors. And again, it really depends on what his symptoms may be and his physical examination. All that really matters. I would test his exercise tolerance, for example. And after all that, you would have to sit down with the patient and his family and discuss what you think is going on. And everything in medicine comes down to a risk benefit calculation. Everything does. There's no hard and fast rule here, but again, I would want him to be seen by somebody who knows how to manage concussion in that area and have a thorough evaluation, and then discuss, what are the risks and benefits of him continuing. I'm sure he can play a different sport, for example. So all that figures into, the calculation here.
Yes. Well, thank you, because they are having that conversation, have been having it since last winter. And I know they're very concerned. And I'm definitely going to tell them about your protocol when I get there with the pediatrician. Okay. So would you advise getting like a functional MRI or an MRI of his brain?
I wouldn't get a functional MRI. That is not ready for prime time clinical use. That is right now a research tool.
Yes.
I would only get an MRI if he was having persistent symptoms and I was worried about what they were, especially if he's having bad headaches, for example, and they're not getting better. So the MRI question is really dependent upon his current symptoms, how much has he recovered, what's his physical examination like. There are other issues here. I don't get MRIs unless I think they're going to change management. Now, if you got an MRI and he had, some evidence of microscopic bleeding or something, that may give you more ammunition for saying to him and his parents, I'm not sure this is the sport for your child. But I don't get MRIs unless they're really indicated. And people may say, well, why don't you? Well, the problem with MRIs is that they're quite sensitive, but they're not specific. And sometimes little dots in your brain are just that, and they're not pathology. So you have to be very careful about when you're going to get an MRI and what you're going to do with the information. I've seen them cause more anxiety than relief in some people. So I'm not saying he doesn't absolutely need one, but I would leave that up to the examining expert in that case. Okay.
Thank you very, very much.
You're welcome. I hope he's okay.
I do too.
Yeah. I was going to add something, but there's a question in the chat here that actually ties to what you were talking about, Jennifer. I think it's relevant. And the question is there any information regarding repeated subconcussive forces, military, bad ski falls without recognized concussion? And the reason why I think that's relevant, Jennifer, is that your grandson, was it?
Yes.
Okay, so he's had 3 concussions. He ski jumps. Every time he lands after a
ski races.
And ski races. So obviously he has a high exposure to repeated head trauma. But every time he lands after a ski jump, you don't necessarily have to hit your head to experience a concussion. And so I've had people who have had several concussions almost fully recover, and then they go on a Jeep tour in Sedona and are jostled around, and all of a sudden all their symptoms come back. So the force that's transmitted to the brain just from him landing on his feet could be one of the subconcussive forces that I think this person is questioning. And we know that there may be cumulative problems that arise because of those repeated subconcussive forces. even if he doesn't experience a concussion with symptoms again. But I'm going to toss that over to John to address that question.
Thank you.
No, David's right. I mean, the thinking now is, I saw something pop up there. The thinking now is that CTE is probably related to the repetitive subconcussive head impacts, not to the number of concussions, believe it or not. That's a common misconception, I think, out there. And that's why, you know, the retired football players, for example, they've experienced, you know, thousands upon thousands of these repetitive head impacts that didn't produce any observable symptoms. So the research on that is evolving. You know, it's part of David's NIH trial. But it does seem like cumulative repetitive head impact, again, probably in a susceptible genotype, is not good for those brains. And we don't know how many is necessary, although coming out of the Amsterdam conference, Dr. Cantu, who's one of the experts in this, said it seemed to be really in retired professional players who had played at least 5 years in their sport. So if you think about it, that's a lot of repetitive trauma over many years in those that make it to the pros. So again, repetitive head impacts are probably what's leading to CTE in some people, not the concussions themselves.
Well, thank you. That's definitely food for thought.
And so there's a comment here, the factor that correlates most closely with CTE is duration of play, not the number of concussions. So John, I think that's what you're alluding to.
Right.
Yeah. And I think there's some evidence that it may actually be related to age of first exposure. So if you start playing football when you're 6 or 7 versus when you're 14 or 15, that may make a difference too, because maybe the brain of a 6-year-old is a little more vulnerable to concussion and may not recover as quickly as that of a 14-year-old or a 24-year-old. So age of first exposure, we think, may be important, although there's some conflicting evidence around that. But I happen to be in the camp that thinks that if you start playing football at 6 or 7, that's not a good thing, especially tackle football. And duration of exposure seems to matter too.
Yeah, and David's right. I mean, David's pointing to the fact that there are these rule changes now to try to make football safer, especially for kids. You know, limiting or no contact in practice for youth football, and really limiting head contact or heading in youth soccer, eliminating checking in Canadian ice hockey. So all those rule changes appear to be making some difference. So we can certainly make contact sports safer, and anything that we can do to do that, we should do that.
And you know it must be serious, John, when you take checking out of Canadian ice hockey.
Yeah, I know. You guys are crazy in Canada.
Brenda.
Hi, thank you. Can you hear me okay?
You can, yes.
Thank you for doing this. If I start to cry, just overlook me. My son was involved in a motorcycle accident 2.5 years ago. And of course, he grew up playing sports, soccer, baseball, all that. But in his accident 2.5 years ago, he was found on the road unconscious with a cracked helmet, a DOT helmet. He was transported in as a level 1 trauma, and we were basically dismissed. He was discharged within 4 hours. He had a head CT, C-spine, a couple x-rays of his arms, and that was it. He basically walked out with a shattered L1, rib fractures, 3rd-degree burns, and TBI. So we went back to his primary care doctor the following week, and we were dismissed again. And then I was left all on my own to try to navigate all of this. So we've been to UVA for his spine. We were told that if he still had symptoms, wherever he was at 1 year from the date of the injury, that's where he would stay as far as the brain injury goes. But we've had no help along the way, and he's dealing with depression, personality changes, memory issues. He has no recollection at all of the accident. And here we are 2.5 years later, and I don't know if it's too late, if there's anything that we can do.
Well, what your son went through is terrible, and it doesn't sound like he got much good advice or treatment. Yeah, I don't think you should just sit by and let him continue to suffer. I think he needs to see what Dr. Dodick said before, a multidisciplinary clinic that treats mild traumatic brain injury and more severe brain injuries. Yes, he can be helped with his depression, and if he's in chronic pain, and his memory is again, there are many causes for memory problems, one of which, or two of which, are chronic pain and depression. So he needs a thorough evaluation by experts in the field. You know, like David said before, a neuropsychological evaluation, a neurological evaluation, an evaluation of his cervical spine. All of this should be done. Evaluation of his oculomotor and vestibular function. These are all potentially treatable conditions. Now, is it a guarantee that it'll return him to his pre-accident status? It's not, but certainly there are multiple potential treatable conditions that he should be availing himself of. He shouldn't just be wallowing in his symptoms at this point. I would encourage you to bring him somewhere that he can get this multidisciplinary evaluation. David, maybe?
I completely agree, Brendan. I'm really sorry for what happened to your son, and there's no way he needs to suffer like this. So there are programs. I mean, the first thing we did at Mayo Clinic when we set our program up was we brought on an exercise physiologist, a vestibular audiologist, but importantly, a neuropsychologist who was an expert in cognitive rehabilitation. So he needs a thorough evaluation to make sure that all contributing factors have been eliminated. And once that's done, then he needs to see a neuropsychologist really who's expert in cognitive rehabilitation. And there are programs around the country that house that multidisciplinary team of experts who assess a patient thoroughly, come together as a team, and decide on a diagnostic and treatment plan. And that's what he needs. And so is there no hope? Of course there's hope. And he absolutely can be helped and can improve. But he just needs to be seen by a team that does this every day. This is what they do.
Right.
Can you advise, just give me some options, because we live in more of a rural area. We're probably 2.5 hours from UVA.
Yeah, we can. If you reach out, Brenda, afterward to American Brain Foundation, we'll make sure to give you some contacts and some leads of groups you should be able to reach out to get help for your son.
Thank you.
You're welcome. Well, unfortunately, John, this is we're at the end of the hour. Thank you so much for being here, and thank you for taking the time and lending your time and expertise tonight. It's a great turnout tonight, and I appreciate everyone coming. I think you heard from certainly one of the leading experts in the field tonight. There's only so much you can cover in 1 hour, and we could easily go on for another couple of hours here. So, John, I think we're going to be bringing you back for an encore presentation to cover other aspects of concussions, because there's a lot we didn't touch on. But thank you again, John, for coming tonight. Appreciate it.
My pleasure, David. It was fun, good questions. That makes it interesting for me. Obviously, very passionate, engaged audience, and that's all you can ask for, right? And I want to thank you for inviting me and the ABF. I want to shout out to my friends Steve Dodick and Sid Hines. I see them on the panel here. I can't see everybody, but nice to see you again, David. And I hope everybody who had a story tonight, maybe they got some information that would help their family members, moving forward. There is hope. David's right, and just got to find the right team and the right person who knows something about concussion treatment. So,
yeah, and if you reach out to American Brain Foundation afterward, we'll be happy to help point you in the right direction. Thanks, everybody. Have a great night.